Okay, close the screen. I am starting. Good evening, all. I am Dr. Sharad Balaji on behalf of PW. We are going to discuss about one important topic in neurology. You all know that there are many symptoms and signs with respect to neurology. You can get seizure, you can get weakness, you can get focal neurological deficit, so many things. We are going to discuss right now about weakness. When anyone presents with weakness, what you are going to think in terms of. So the purpose of this discussion is to find out where the pathology is. We are going to discuss about the symptom weakness. Right. How to elicit the history of weakness in pediatric age group. Let us see one by one. First point. How will you elicit proximal muscle weakness? Proximal muscle weakness. How you will elicit? Point number one. When you have involvement of upper limb proximal weakness, you will unable to lift the shoulder, unable to comb, you can't comb. Proximal involvement of lower limb, what will happen? You cannot sit from a supine position, or you cannot stand from sitting position. This is proximal muscle involvement of upper limb and proximal muscle involvement of lower limb. When you have distal muscle weakness, how you will elicit distal muscle weakness? Very, very easy. So upper limb, lower limb. Upper limb, you can't button or unbutton. You can't button or unbutton. Distal muscle weakness. With respect to lower limb, you cannot hold the slippers. You can't hold slippers in legs. Then, what will be the complaint with respect to facial weakness? How you will elicit? You need to ask the history of ptosis. You need to ask the history of ptosis. Facial weakness will manifest with ptosis. And bulbar weakness involving your 9, 10, 11 nerves, 9, 10, 12 nerves, bulbar weakness. How you will elicit this history? The bulbar weakness can be elicited by asking the following questions. Is there any problem with respect to swallowing? Second, is there any dysarthria? Is there any nasal twang of speech? Is there any aspiration while feeding? Is there any aspiration while feeding? This is with respect to bulbar weakness. Truncal weakness. How you will elicit and what are all the questions you will hear with respect to truncal weakness? Whether you will able to turn around either right lateral or left lateral. Whether can you able to turn the child, whether the child by itself can turn to the right or left, or whether the child is able to sit from the supine position or stand from the sitting position. So this is how you need to elicit the history of weakness. Proximal muscle weakness of the upper limb, unable to comb. Proximal muscle weakness of the lower limb, unable to stand. Distal muscle weakness of upper limb, buttoning and unbuttoning will be difficult. Distal muscle weakness of the lower limb, unable to hold the slippers in the lower limb. Facial weakness will manifest with ptosis. Bulbar weakness is characterized by swallowing issues, speech issues, nasal twang of voice, and aspiration while feeding. Truncal weakness, unable to turn to the right lateral or left lateral position. So these are all the type of weakness that you can elicit from the history. Then you know that the child is having some sort of weakness. Now you want to know where the site of pathology is. So how to elicit the site of pathology? Broadly, we will classify it as whether it is upper motor neuron or lower motor neuron. Let me say, weakness can be due to either upper motor neuron or lower motor neuron. So let me write, the child is having weakness. That weakness can be upper motor neuron or motor unit. Motor unit. Upper motor neuron means it is mainly cranial nerves. It involves your brain, central nervous system. Whereas, what does a motor unit includes? A motor unit includes anterior horn cell. From that, you will have a peripheral nerve. Now, from the peripheral nerve, you will have neuromuscular junction, and finally it will end up in muscle. So you can have problems in the upper motor neuron, or else you can have a problem in the lower motor neuron. Lower motor neuron includes your anterior horn cell, peripheral nerve, neuromuscular junction, and muscle. Or else I can say anterior horn cell means neuronopathy. Peripheral nerve means neuropathy. Whereas neuromuscular junction is called as neuromuscular junction disorders. And muscle either can be muscular dystrophy or myopathy. We will be discussing in other sessions also. So point number 1, where the weakness is. Point number 2, whether it is upper motor neuron or it involves the motor unit. How to differentiate between an upper motor neuron and a lower motor neuron? Upper motor neuron means central nervous system. So what will happen? Upper motor neuron is characterized by altered sensorium. Cortical involvement often leads to seizures. So whenever you have weakness along with the altered sensorium, along with seizures, think in terms of central nervous system involvement. Tone. Whenever pyramidal tract is involved, what will happen? Tone will be increased. Reflex will be exaggerated. Exaggerated deep tendon reflexes. And finally, plantar will be extensor. Whereas, what happens in lower motor neuron starting from your anterior horn cell? Whether it is anterior horn cell, peripheral nerve, neuromuscular junction, or your involving muscles. Sensorium will be intact. I repeat, sensorium will be intact in weakness that is caused as a result of motor unit. There will not be any seizures. No seizures at all. Tone. Invariably, you will have hypotonia. And you will have profound weakness. Reflexes usually reduced. Diminished. And finally, plantar is flexor. I repeat, upper motor neuron, sensorium is altered, lower motor neuron intact. Seizure manifestation of upper motor neuron, no seizures in case of lower motor neuron. Tone is increased in upper motor neuron, low and profound weakness in case of motor unit. Reflexes are exaggerated in upper motor neuron. Reflexes are reduced, deep tendon reflexes are reduced in lower motor neuron. And finally, plantar is extensor in case of upper motor neuron, and plantar is flexor in case of lower motor neuron. Now you know how to elicit the history of weakness. Second point is how to differentiate between an upper motor neuron and a lower motor neuron. Third one, what does a lower motor neuron involves? It involves anterior on cell, peripheral nerve, neuromuscular junction, and muscle. It was discussed right now that motor unit, your lower motor unit involves your anterior on cell, nerve, neuromuscular junction, and muscle. A child can present with profound weakness. Is it possible to differentiate where the site of pathology is? Whether it is due to lesions in the anterior on cell, or whether the lesion in the nerve, or neuromuscular junction, or muscle, how to elicit or how to differentiate weakness due to which site of pathology is involved. For that, you need to ask simple questions. What about the weakness? Where it is present? What about the reflex? What is the characteristic features? What is the age of involvement? Let me say, anterior on cell involvement is characterized by both generalized weakness involving both proximal and distal muscle. So weakness in case of anterior on cell is generalized. That means both proximal and distal are involved. Proximal and distal muscles are involved. Point number 1. 2. What about reflex? Areflexia. I repeat, it is characterized by areflexia. Reflexes are totally absent. What is the characteristic feature? The characteristic feature is tongue fasciculations. The characteristic feature is tongue fasciculations. I'll show you what does a tongue fasciculation look like. An age of presentation is early age of onset. It can present even in the infantile stage. So it can present less than 1 year. What are all the manifestations? What is the classical example that I want to give? It is nothing but spinal muscular atrophy. The classical example is spinal muscular atrophy. The child will be floppy with frog leg position. Usually having respiratory infections as a result of poor tone. The child will be ventilator dependent because of the weakness involving the respiratory muscles. Classical example is, I repeat, spinal muscular atrophy. It involves both proximal and distal muscle, characterized by global areflexia. Tongue fasciculation is characteristic. Early age of onset. Most common cause is spinal muscular atrophy. The manifestations are floppy, frog-leg position, along with recurrent aspiration pneumonia, ventilator dependency, and feeding issues. I repeat, classical example is spinal muscular atrophy. When it comes to nerve, what happens? The characteristic feature of where does the weakness involve? Weakness is usually distal more than proximal. Reflexes reduced but not absent. What is the characteristic feature? Here there are some involvement of sensory nerves. So sensory involvement will be there because it involves the peripheral nerve. Age of onset is later age of onset. Later age of onset. What is the characteristic examples that I can give? You all know that one is congenital. What is the congenital most common hereditary neuropathy occurring in children? Can anyone tell me? Most common hereditary neuropathy of children is what? Most common cause for peripheral neuropathy in children is what? Very good. It is Charcot-Marie tooth disease. It can be congenital or acquired. The characteristic congenital peripheral neuropathy or hereditary neuropathy in pediatric age group is Charcot-Marie tooth disease, characterized by peroneal muscle atrophy leading to foot drop. This is congenital. What is the acquired form? You all know. What is the acquired form? Can anyone tell me what is the most common acquired peripheral neuropathy? Exactly. It is Guillain-Barré syndrome. Acute demyelinating polyneuropathy. Guillain-Barré syndrome is the most common acquired peripheral neuropathy in children. It can be either demyelinating or it can be due to axonal injury. I repeat, peripheral nerve involvement is characterized by distal rather than proximal, characterized by reduced reflexes. Sensory nerve involvement is present so that you can get trophic ulcers. Usual age of presentation is later, childhood age is the presentation. It can be congenital or acquired. Congenital is Charcot-Marie tooth disease. Acquired is Guillain-Barré syndrome. And what about neuromuscular junction? All of you know the most common condition affecting your neuromuscular junction is very good. Myasthenia gravis. In pediatrics, we used to call it as juvenile myasthenia gravis. What is the weakness here? Weakness mainly involve bulbar. So what does it mean? You will have swallowing difficulty. You will have dysarthria. It can involve your eyes, external ophthalmoplegia leading to ptosis. So one is ophthalmoplegia. Second is bulbar leading to swallowing difficulty and dysarthria. And it can also present with proximal muscle weakness, and at times it can present with respiratory failure. Sudden onset respiratory failure. What is the feature of neuromuscular junction disorder? Morning, I am speaking with a loud voice, but gradually as the time progresses, my voice gradually reduces. So what is this called as? Diurnal variation or fatigable weakness. So what is this called as? It is called as diurnal weakness. Will have diurnal variation. Morning he will be fine. Evening he will have weakness, otherwise called as fatigable weakness. Fluctuation is the characteristic feature of neuromuscular junction disorder. Fluctuation. That is the characteristic feature. Reflexes. Usually reflexes will be intact. Age of onset variable. Most common cause is juvenile myasthenia gravis. And finally, muscle. What is the feature of muscular involvement? If the weakness arises as a result of muscle involvement, what will happen? It is profound weakness. Reflexes. reflexes are DTR proportional to degree of weakness. Proportional to degree of weakness. So in the initial stages, reflexes will be intact, but gradually because of a relentless progression of weakness, finally deep tendon reflexes will be reduced. I repeat, reflexes are directly proportional to the degree of weakness of the muscle. Feature, I repeat, relentless progression. It progresses like anything. Relentless progression. Age of onset. Age of onset varies. How does the age of onset varies? It can be due to myopathy, congenital myopathy, which has neonatal or infantile onset. Neonatal or infantile onset. So what are all the congenital myopathies? You all know congenital myopathies are Nemelin. What are all the congenital myopathies? Can anyone tell me? One is Nemelin, central core myopathy, centronuclear. Okay, and there are some types which will be discussed in our session along with our medicine faculty. So myopathy, so muscle involvement can be due to myopathy, which are due to ultrastructural problems in the muscle apparatus. Ultrastructural problems in muscle apparatus. Problems in muscle apparatus. What are all the age group? Infantile or neonatal. Nemelin, central core, central nuclear, as well as one more. What is that one more? Congenital muscle fiber disproportionate type. Congenital muscle fiber disproportionate type. I don't think you need to know all these things. Just remember, myopathy can have neonatal onset or infantile onset due to issues in the ultrastructural problems involving the muscle apparatus. And finally, it can be due to muscular dystrophy. Finally, it can be due to what? Muscular dystrophy. Muscular dystrophy. And the most common muscular dystrophy, as you all know, Duchenne muscular dystrophy, Becker muscular dystrophy, facioscapulohumeral dystrophy, myotonic dystrophy, and limb girdle muscular dystrophy. Limb girdle muscular dystrophy. So these are all the muscular dystrophies. Duchenne, Becker, facioscapulohumeral, myotonic dystrophy, and limb girdle muscular dystrophy. So let me revise. Weakness can be proximal muscle weakness, distal muscle weakness, facial weakness, truncal weakness. 1. It can be due to upper motor neuron or lower motor neuron. Lower motor neuron means it is usually the motor unit which involves the anterior oncell, otherwise called as diseases involving anterior oncell is called as neuronopathy. The most common example is spinal muscular atrophy. Second one, diseases involving nerve is called as neuropathy. It can be congenital or acquired. Congenital means Charcot-Marie tooth disease. Acquired means Guillain-Barré syndrome, which again can be divided into either demyelination or axonal injury. Anterior oncell is characterized by tongue fasciculations. Peripheral nerve is characterized by sensory nerve involvement. Whereas neuromuscular junction, the disease is juvenile myasthenia gravis. And it is characterized by fatigable weakness. Morning, I can open my eyelid. Evening, I will develop ptosis. Morning, I can speak. Evening, I will develop dysarthria. So juvenile myasthenia gravis is the example. And then muscle. It can be either myopathy involving the ultrastructural elements of contractile unit, or it can involve the proteins involving the sarcolemma. That is your myotonic dystrophy, which are characterized by degeneration of the muscle leading to elevation of CPK, otherwise known as creatine phosphokinase. Creatine phosphokinase. Myopathy, early age of onset, whereas myotonic dystrophy, variable age of onset, whereas muscular dystrophies are characterized by later age of onset during childhood period. Let me show you some videos which will be helpful to get some clinical diagnosis. Look at these videos. So, can you tell me what is this? Can anyone tell me what is this? What is this? Can anyone tell me what is this? Beautiful. What is this? Tongue fasciculations. Look at the tongue fasciculation. Tongue fasciculations are characteristic feature of what? Spinal muscular atrophy. I repeat, tongue fasciculations are characteristic features of what? Anterior onsal involvement. The most common example is spinal muscular atrophy. Look at this. What happens here? The child is having ptosis. So what does ptosis indicates? What does ptosis indicates? Ptosis indicates myasthenia gravis. Either it can be congenital myasthenia, myasthenic syndrome, or it can be due to myasthenia gravis. So look at the legs of the child. Look at the legs of the child. Look at his legs. How he is walking. What is this walking called as? This walking is called as what? Foot drop. Why? Because of the weakness involving the peroneal muscles. Because of the weakness involving the peroneal muscle. The otherwise known as, because of the profound weakness of the peroneal muscles, it is called as what? Stark leg appearance. Characteristic feature of what? Charcot-Marie tooth disease. And finally, what is this? And finally, look at this. Finally, look at this. What is this? This is called, what is this? This is called, you all know, that is called as Gower sign, involving proximal muscle weakness of the lower limb, characteristic of Duchenne muscular dystrophy. Characteristic of Duchenne muscular dystrophies. Right. So today I am going to touch only muscular dystrophies. What are all the muscular dystrophies? The muscular dystrophies can be X-linked. Your Duchenne muscular dystrophy and Becker muscular dystrophy are X-linked. Whereas your myotonic dystrophy and scapulohumeral dystrophy are autosomal dominant. Whereas limb girdle muscular dystrophy can be either autosomal dominant or autosomal recessive. So the only thing where you need to ask the consanguineous history is limb girdle muscular dystrophy. If only male members are affected, either it can be Duchenne or Becker. Right? So X-linked is Duchenne muscular dystrophy and Becker muscular dystrophy. Autosomal dominant or myotonic dystrophy and facioscapulohumeral dystrophy. Limb girdle muscular dystrophy can be autosomal dominant or autosomal recessive. Now, let me touch some of the important aspects of Duchenne muscular dystrophy and Becker muscular dystrophy. You all know that your Duchenne muscular dystrophy and Becker muscular dystrophy are X-linked. So only The major manifestations will be seen mainly in males. So what are all the types? More severe is Duchenne. More severe is Duchenne. Less severe is Becker. So what does it mean? Duchenne means the onset usually less than 3 years, and the child will become chair bound by 9 years or 10 years, die by about 20 years. Whereas Becker onset is more than 3 years, chair bound by about 20 years, death by about 30 to 40 years. Because in Duchenne there are no dystrophin gene, whereas in Becker there are some dystrophin gene. Chromosome, as you all know, it is short term of chromosome uh, X involving the 21st band. If it completely involves frame shift mutation, it can lead to stop codon, leading to Duchenne muscular dystrophy, because all dystrophins are lost because of this point mutation. Whereas in-frame mutation means some dystrophin is retained. I repeat, some dystrophin is retained, as a result of which you will get Becker muscular dystrophy. All manifestations will be there, but later age of onset. Incidence 1 in 3,500 male births. 1 in 3,500 male births are involved. What is the manifestation initially? What is the initial manifestation? Less than 3 years, the child will have motor developmental delay. The child will have frequent fall. The child will have frequent fall. Okay, the child will have lumbar lordosis. Lumbar lordosis. Between 3 to 6 years, the child will develop waddling gait because of the involvement of the proximal muscles of the lower limb along with the Gower sign. Along with Gower sign. Gower sign. And the disease attains its plateau, profound weakness, by 6 to 10 years. 10 years. By about 10 years, the child cannot walk and leading to chair bound. He will become chair bound by about 10 years. He cannot walk. There are so many cases we have. Chair bound. And then what will happen? Once he became chair bound, there will be kyphoscoliosis. And once there is kyphoscoliosis, it can lead to recurrent respiratory infections, and death is mainly due to aspiration pneumonia. You all know cough hypertrophy is one of the manifestation of Duchenne and Becker muscular dystrophy. Along with that, you will have hypertrophy involving tongue, your masseter, your deltoid, and then infraspinatus muscle, and then infraspinatus muscle. These muscles will undergo hypertrophy. It is otherwise known as pseudo hypertrophy. Why it is called pseudo hypertrophy? It is not the muscle. The muscles are replaced by fat. That's why you will have profound weakness. Stomach, the child can go for gastric volvulus as well as gastroparesis, indigestion, sudden vomiting. And finally, the last to be affected is the respiratory muscles. Your diaphragm and then intercostal muscles are last to be affected. So respiratory failure usually occurs by about 20 years. not only due to weakness of the respiratory muscles but also due to underlying kyphoscoliosis, as a result of which the child will have a restrictive lung disease from 10 years of age. Remember, these it not only affects your skeletal muscles but also affects your cardiac muscle, leading to dilated cardiomyopathy, leading to cardiac failure, and many times because of the dilated cardiomyopathy the child will die of arrhythmias. The child will die of arrhythmias. So respiratory failure, recurrent aspiration pneumonia, and arrhythmias are the most common cause for death in Duchenne muscular dystrophy as well as Becker muscular dystrophy. What is called valley sign? It is due to hypertrophy of deltoid, hypertrophy of infraspinatus, but there is wasting of posterior axillary fold. Posterior axillary fold. So you will have a deep dent in between your deltoid and infraspinatus above, a deltoid above, infraspinatus below, and in between there is wastage of the posterior axillary fold. This is called valley sign. So you will get two signs in case of Duchenne muscular dystrophy. One is Gower sign, another is valley sign, and also you need to remember waddling gait. What is Becker? As explained already, some dystrophins are present, so manifestations are little bit late, but invariably the same fate. Whatever that had occurred in Duchenne muscular atrophy will occur in Becker muscular dystrophy also. And finally, we all know that this Duchenne and Becker are X-linked recessive. Do it has any manifestation in girls? The answer is yes. Girls can have calf muscle hypertrophy along with that, but they don't have weakness. They don't have weakness because they have 2X chromosome. They don't have weakness. But one important point, they are more prone for dilated cardiomyopathy as well as they are more prone for arrhythmias as a result of dilated cardiomyopathy. Okay? Right. And remember, whenever any boy comes with weakness, cannot able to stand, cannot climb, paddling gait, the first investigation that we do is creatine phosphokinase. The usual value is less than 150 milligram per deciliter, but in children with Duchenne muscular dystrophy, it will be 10 times the normal value. Remember, degree of increased CPK elevation doesn't mean that there is increased weakness. It doesn't correlate because at the end of extreme weakness, when all muscles are replaced by fat, the muscle cannot produce leak any CPK. As a result of which, at the end stage, CPK will be normal or low. At the end stage of Duchenne muscular dystrophy or Becker muscular dystrophy. Remember, the muscle also contain this SGOT. That's why any boy with elevated SGOT, you need to also think in terms of Duchenne muscular dystrophy. Not only you need to think in terms of liver disorder. I repeat, any boy with the delayed milestones along with elevated SGOT but normal SGPT, think in terms of Duchenne muscular dystrophy. Right. What is the investigation of choice? There is no need to do any biopsy. No need to do any biopsy. What is the investigation of choice? The investigation of choice is PCR analysis to find the mutation. Either it is next generation sequencing or MLPA. Okay, either you can do NGS, next generation sequencing, or you can do MLPA. Right, this is the investigation of choice. Majority of these cases can be detected by this investigation. If your mutation turned out to be negative, whether if your MLPA is negative or NGS is negative, you need to go for muscle biopsy, where you need to look for dystrophin stain in the muscle. If there are no dystrophin stain, it can be due to Duchenne muscular dystrophy. If there are some stains, it is usually due to Becker muscular dystrophy. The cause of death, as you all know, it is respiratory insufficiency and pneumonias, as well as arrhythmias. Arrhythmias, most common cause of death is arrhythmias. Remember, by about 10 years of age, there will be, when the child becomes chair-bound, there is kyphoscoliosis. So, you need to do a pulmonary function test. When your FEC falls more than 20% compared to daytime, the child is more prone for nocturnal hypoventilation, respiratory failure during sleep. Okay. Second point, echo. Why? Because they are more prone for dilated cardiomyopathy, leading to poor ejection fraction. And finally, DEXA. When you don't go out, your bone density will fall down, which can be identified by doing a DEXA scan. And finally, what is the treatment of choice? Steroids. What are all the steroids you can use? Either you can use prednisolone or you can use deflazacort. It just postpone the ambulation. Anyway, the child is going to be chair-bound. If you don't use steroids, the child will become chair-bound by 10 years. If you use steroids, the child will become chair-bound by 13 or 14 years. Steroids are not the drug of choice. They will postpone the degree of weakness. Right now, we have drugs which can act at the level of gene. Two drugs are approved. One is ertiplursin, another is ataluren. Still, we need to get all these drugs in our country. Once people start using more and more of these gene splicing drugs, ertiplursin and ataluren, we will come to know how much of significant benefit that it can produce in those children with profound weakness. So we have completed your Duchenne and Becker muscular dystrophy. And then let us go to myotonic dystrophy. Myotonic dystrophy is the most common muscular dystrophy in adults but not in children. There are many characteristic features of myotonic dystrophy that differentiate itself from other cause of muscular dystrophies. What are all they? 1. What is the mutation? It is CTG trinucleotide repeat. Nucleotide repeat. Inheritance is autosomal dominant. What is the age of presentation? It can present in newborn, it can present in infant, it can present in child, or it can present in adult. At any age, it can present with. What is the characteristic feature? Usually, muscle is characterized by proximal rather than distal weakness. Muscular involvement is characterized by proximal weakness. The only muscle involvement that leads to distal rather than proximal is myotonic dystrophy. So it is more of distal rather than proximal. All muscular issues will have proximal muscle involvement. The only muscular myotonic dystrophy is the only condition which involves muscle but distal rather than proximal. And what is the characteristic symptom? All are characterized by weakness, but myotonic is characterized by stiffness. So, whenever you give a handshake to children with myotonic dystrophy, they will not leave your hand because of the increased stiffness. So, it is stiffness compared to weakness. Weakness. Remember, as I told you, varied age of presentation, distal more than proximal, stiffness rather than weakness are features of myotonic dystrophy. Other system involvement. It can lead to posterior subcapsular cataract. It can lead to endocrine disturbances. It can have frontal baldness. Because of the involvement of facial muscles, because of the involvement of facial muscles, you'll have dragging of the mandible leading to inverted V-shaped mouth, inverted V-shaped mouth, and in EMG you will have one pattern. What is the pattern called as? You will get a revving engine sound. What is called a revving engine sound? Whenever our boys see some girls, they will drive, they will give accelerator when they are driving. So you will get a sound that is called revving engine sound. In electromyography, you will get this revving engine sound in case of myotonic dystrophy. And finally, what are all the drugs? You can use sodium channel blockers. You can use tricyclic antidepressants. No specific drugs with respect to myotonic dystrophy. And finally, facioscapulohumeral dystrophy. You must have seen in famous cartoon show what is called as Popeye. Okay, Popeye show you have seen. So in which he has atrophy of biceps and triceps. Usually will have good biceps, good triceps. But Popeye, the inverse happens. Deltoid is hypertrophied, brachioradialis is hypertrophied, wasting of biceps and wasting of triceps. So facioscapulohumeral dystrophy is characterized by facial weakness leading to round mouth. Leading to what? Round mouth. Inverted V-shaped mouth in case of myotonic dystrophy. Round mouth in case of facial weakness. Also you will get ptosis. Okay, what is called Popeye sign? There will be weakness of biceps, triceps, whereas hypertrophy of deltoid and brachioradialis. Because of the weakness of the scapula, you will get winging of scapula. You will get winging of scapula, scapular winging. And you will have weakness of lower abdomen more than upper abdomen. Weakness of lower abdomen. Weakness of lower abdomen more than upper abdomen. That is, abdomen below the level of umbilicus has got profound weakness. And this is called as beaver sign. This is called as beaver sign. So you will get round mouth, ptosis, winging of scapula, Popeye sign, beaver sign. In case of facioscapulohumeral dystrophy. This is also characterized by other system involvement in the form of Coats disease involving your retina. Coats disease involving your retina. And what is the inheritance? As I told you, like myotonic dystrophy, it also has autosomal dominant inheritance. Like myotonic dystrophy, this is also characterized by repeat. The repeat is called D4Z4 repeat. So this is called facioscapulohumeral dystrophy. What are all the things you need to remember? Ptosis, round mouth, winging of scapula, Popeye sign, as well as beaver sign. Other system involvements is Coats disease. And finally, limb girdle muscular dystrophy is more of a adult type of muscular dystrophy that will be discussed with my colleague Dr. Santosh during our discussion in muscular system. So with this, we are finishing our topic on an approach to weakness, how to differentiate between upper motor neuron and lower motor neuron. When it comes to lower motor neuron, how to differentiate between neuropathy, myopathy, neuromuscular junction, spinal muscular atrophy, anterior onset, Charcot-Marie tooth disease and Guillain-Barré syndrome, peripheral nerve, juvenile myasthenia gravis, neuromuscular junction. Muscle involves myopathy, congenital, and then muscular dystrophy, leading to relentless progression and weakness. We had discussed in detail about only three: Duchenne muscular dystrophy, facioscapulohumeral dystrophy, and myotonic dystrophy. With this, I am finishing the topic for today. Thanks for your patient listening. If you have any doubt, please ping me. Thank you, Team PW. Thank you, my dear students. The session is closed for now. The session is closed. Over. Hello.